right, everyone, so we'll go ahead and get started on Chapter 12, Principles of Pharmacology. Good stuff. So, understandably, EMTs don't do a lot of uh, medication administration, right? We do nitroglycerin, aspirin, epinephrine, albuterol. Namely, those are the major ones, where we assist in the administration of those nationally. But the important thing is that we experience and we run a lot of patients that are taking medication. So this isn't just how do you administer medication, right? This is more so like when we run calls and we encounter patients, what do the medications that they're taking mean to us? So obviously you're not expected to know every single medication or exactly how these work. That's not the idea of what EMTs do. These are easily, you could easily look these up. This is more like foundational stuff, right? Like, or principles of pharmacology, okay? So we'll go ahead and get started. Um, Now that we start off with just some general drug terminology that kind of lays a foundation as we move forward throughout this chapter, okay? So pharmacology is the study of properties and effects of drugs and medications on the body, okay? Pretty reasonable. That makes sense, okay? And then drugs are chemical agents used in diagnosis, treatment, and prevention of disease. Comparatively and very similarly, medications are chemical substances used to treat or prevent disease or relieve pain. So you'll see that these two are very similar to each other. I won't spend too much time figuring out the exact difference between the two. At least I won't test you on the exact difference between the two. These are used interchangeably, typically. I'm not saying they are the same thing, but they are interchangeable. Okay. Now, a dose is the amount of medication that is given. So we tend to do this in like milligrams, milliliters, deciliters, micrograms, right? We don't use ounces or anything like that typically in real medicine, right? You might see that on like children's Tylenol and stuff like that, but almost always we'll use milliliters, milligrams in medicine. And then so the dose can change, obviously, based on patient's weight and how much of what's the therapeutic index of the drug and the toxicity of the drug and all those things, okay? And then action. So this is the therapeutic or intended effect a medication is expected to have on the body. So the action of a drug is basically, like I'll give you an example, like diphenhydramine, which is Benadryl. Okay, so diphenhydramine would be the generic, and Benadryl would be the trade name. So the action of this drug is to block histamine, right? And so it's an antihistamine. So antihistamine. So if someone asks you what's the action of diphenhydramine, also known as Benadryl, the answer is it is an antihistamine. It blocks histamine. Okay. So unintended effects, right? These are effects that are undesirable but pose little risk to the patient. Uh, so an example of like a nausea would be an example, right? It's not desirable to be nauseated, but it's not going to cause a massive amount of risk or harm to the patient if they get episodes of nausea while taking a medication. Okay. An untoward effect, right? So this is a little more severe. This is effect that could be harmful to the patient. So this could be low blood pressure or high blood pressure, or it could drop their blood sugar too low or something like that. So these are effects that actually can cause harm to the patient. So these are things that we're a little bit more cognizant of and pay attention to. So, an example of, medications that we give, like we could just use epinephrine, for example. If you give epinephrine to someone who's having a heart attack, right, it's going to cause the untoward effect of, cardiac toxicity and probably further their heart attack. So that would be an example. Okay. Now, toxicity, every substance on earth is toxic in the right amounts, including water, including salt, including oxygen, right? Everything does have a toxic limit, okay? And that's important to realize that yes, water, oxygen, they can still reach toxic levels. But we have this thing called the therapeutic index of what's the line, right? We could draw this. Whoops. Right? What's the line between that's therapeutic, right? The red line's therapeutic, and this blue line's toxic. And somewhere in between here is the therapeutic index, right? Somewhere in between here is you're somewhere between, yeah, you're providing therapy and you're at the therapeutic threshold. And if you go over this blue line, you're going to be in the toxic area. So everything has and reasonably, the wider the therapeutic index, the more safe a drug is. So a drug like oxygen has a very wide therapeutic index, as opposed to a drug like digoxin has a very narrow therapeutic index. So yeah, toxicity is pretty obvious, right? It's the risk that a substance will pose a health hazard to an individual or organism. Okay, and yeah, that's all I have to say on that for now. Okay, so the indication is the reason that you give a medication. So, you'd be indicated to give epinephrine, Benadryl, albuterol in the case of anaphylaxis. So, we could go a step further with epinephrine, right? Or we'll just use like another EMT drug like albuterol. Sure, yes, it's used in asthma, but it could also be used off label for like as a tocolytic or to lower potassium or stuff like that. So just know that drugs are not there are certain drugs that only have one indication, but the majority of drugs have a wide variety of indications, meaning you can give it for the same drug can be used for a lot of different reasons, a lot of different indications to give it. Okay, so when you hear the word indication, I want you to think the reason you're going to give it. Okay, the therapeutic use of the drug. Contraindication. So this is times when you should not give a patient medication. So an example, right? It is contraindicated to give nitroglycerin to someone who's taking erectile dysfunction medications like Cialis or Viagra, right? It'll drop their blood pressure too low. So that's an absolute contraindication. You cannot give nitroglycerin, which is an EMT basic drug that we use to treat chest pain, to someone who's taking erectile dysfunction medications like Cialis or Viagra. So it could actually be fatal if you do. So that's an absolute contraindication. And I just used a word, an absolute contraindication means it's absolutely contraindicated. You cannot combine, you cannot give that medication, nitroglycerin, when they are taking Cialis and Viagra. Now, there's things called relative contraindications. This gets a little bit complicated, but this is like giving albuterol to someone who's already tachycardic. It's generally contraindicated, meaning you probably shouldn't do that. But there are times where the risk versus the reward outweigh it, and that's an important general concept of pharmacology. Virtually every, I mean, I just told you, every medicine has a toxic level, right? So we, as as paramedics and EMTs and physicians and nurses, we have to weigh the risk versus reward of like, okay, we're going to give epinephrine or albuterol or nitroglycerin or aspirin or whatever drug we're going to give, because we think that the reward will outweigh the risk of giving this medication. And so that's something that I challenge you to think about every time you're about to administer or assist administering a medication to a patient is, rule number one in medicine, do no harm, but does the risk outweigh the reward? That needs to be a personal checklist that you're checking before doing interventions, especially medications. Okay? So, interestingly, drugs are derived from four principal sources, okay? Animals, so insulin's not anymore, but it used to be derived from pigs, okay? Glucagon used to be derived from pigs. Um, Vegetables, okay? The medication simvastatin used to be derived from beet juice, from beets, like the beet, okay? Minerals, obviously magnesium, zinc, iron, those are minerals. Synthetic compounds, I wouldn't say the majority, but a lot of medications now are created synthetically in a lab, and that's probably the dominance of the marketplace right now. Another example of a vegetable or of a plant where we get medications is a medication called atropine. It comes from the belladonna flower, right? And that's a plant. Whoops, belladonna. I don't know why I'm telling you all that, but that's a medication that's carried on ambulance for low heart rate that paramedics give. So just realize that we get medications from different sources, and there's medications from tree barks and all these different ways that we'll create medications to treat patients. Now, this is an important concept that you have to understand the whole difference between what's called a trade name and a generic name. So a trade name is like I want you to pay attention to this whole like restricted copyright thing there, right? This is like a copyrighted, like someone owns this and makes profit off the name of this. So the example I have up on the screen is Tylenol. That's a trade name. Okay, Bayer owns Tylenol. And so a company owns the word Tylenol and they get to slap it on acetaminophen. What's acetaminophen? That's the generic name. Okay, so the generic name for Tylenol is acetaminophen. And this kind of makes sense. When I think of trade name, I kind of think of the stock market, right? To where like those are day traders and they're trading stock, to where they're kind of trading, like they're trying to make money. And so trade names make money. And so people recognize the word Tylenol really quick before they recognize, you know, acetaminophen. Same with Benadryl. So if I give you the word Benadryl, is that a trade name or a generic name? It's a trade name. And what's the generic? It's diphenhydramine. I could do the same, Adderall, right? Adderall is a trade name. What's the generic? It's amphetamine salts, okay? So just realize there's a lot of medications. When medications are introduced to the market in current day, they will always have a trade name. And then after time, the patent on that will expire. And then generics, other drug manufacturers can go create that drug at a cheaper price. So as a generality, trade names are more expensive. If you were to go to Walgreens and buy name brand Tylenol and then look right next to it and buy acetaminophen, same drug, right? The Tylenol is going to be more expensive. It just is. And interestingly, people are generally willing to pay for that. I don't know why, but they are. And I'll say that. I think there can be a difference in trade name and generic names in pharmacology. I'll admit that. But there's not supposed to, but I think anecdotally there is, okay? So chemical name, this is the price description of the medication's chemical composition and molecular structure. You don't need to know chemical names in EMT school or even medical school, but it's there. It is a name, okay? And then the official name is the name assigned by the United States Pharmacopoeia. So the USP is an organization that kind of like catalogs and accepts medications. So if you've ever seen like vitamins that will say like calcium D3 USP, right? It's saying that like their concentration has been accepted by the United States Pharmacopoeia, so it's almost like a form of legitimacy. Okay, so that's kind of just like a weird example, but the USP is the United States Pharmacopoeia. Chemical name, I'm not going to read that to you, right? Generic name, I don't know why they get this is like a really weird example, right? Bleclomethasone dipropionate, right? And the trade name would be Vanseril. And so let me tell you why trade names exist initially. It's for marketing, and it's because it's a lot easier. They'll usually make trade names catchy, right? So, like, if you're a patient or a physician, right, and are you going to be like, want to write out Vanseril, or do you want to write out beclomethasone dipropionate, right? So, of course, they try to make these catchy. This is just a big marketing gimmick, but it works, and so that's where that happens. Remember, the official name will have USP behind it. If it's a real drug, and that means it's recognized by the United States Pharmacopoeia. So prescription medications, right? This is very obvious, right? Shocker. They're distributed by pharmacists. They require a physician's order of prescription. Okay. Um, and then over the counter medications, these are medications that can be purchased without a prescription. Now, there are medications that are sold, like I'll give you an example, Plan B, right? It's emergency contraceptive. That's typically sold, quote, behind the counter, right? So you can't just usually walk into Walgreens and buy it like a Plan B or Narcan or expensive medications like that are at high risk for theft. So there are medications that are sold literally behind the counter, but they don't require a prescription. So the whole over-the-counter thing is a little bit confusing to students sometimes. You need to know that over-the-counter simply means it doesn't require a prescription for you to purchase it. Okay. Now, with that said, there are concentrations of medications that do require prescriptions. So there's certain topical steroids, right? For example, that you could go buy hydrocortisone cream over the counter right now. But if you want a higher concentration, you would have to have a prescription. So it's not necessarily just the drug, it's the concentration, the dosage, the duration, the formulation, the application, right? There's different ways that we can prescribe drugs that change whether the government's decided you need a prescription or not. Okay? So where do we get good drug information? Okay, I will say that apps like the internet at this point has some pretty good resources on how to get information on drugs. And this would probably be, as in 2023, the first place that we go. But there are other options, right? So the United States Food and Drug Administration Center for Drug Evaluation and Research, right? So I guess you could look it up there. This actually, I used to work on it for an ambulance in Erath County, which is the Stephenville area. We didn't always have cell service. So we actually carried a PDR, like a physician's desk reference. It's this huge book that physicians can reference for medical information. To where if we had to look up like procedures or like a disease or a medication, we could look in the PDR. So that's a good place to look up drugs. The hospital formulary. So hospitals will have like a formulary, like a drug list of medications that they stock and that they're aware of, or that they have access to, or they can order. And so they maintain those, and that's one place you could look for drug information. Drug inserts. So if you've ever opened up like a drug box, you've probably noticed like this folded up piece of paper that's printed on Bible paper with Bible print, that has all the drug information on it, including some clinical trial information and efficacy and toxicity and all the weird stuff about it that we don't really care about, but they're obligated to provide that to you. Okay, so that's one place to go. But I would say the internet, like Hippocrates or like drug.com, or not drug.com. Now, let me look real quick. I use this pretty often. Yeah, drugs.com. It's called drugs.com and it's free. Really good app. So you can just type in drugs there and you can look at different indications and dosage and stuff like that. Okay. So the United States regulation of pharmaceuticals. So pharmaceuticals are really regulated in the United States, and this is helpful, and it's also, I wouldn't say harmful. It's just annoying sometimes. Um, But overall, it's helpful because the good thing is, if you get a prescription in the United States, a legitimate prescription, and you're dispensed a legitimate medication from like a legitimate pharmacy, you don't doubt if it's real or not. And right now, I live about 30 minutes from Mexico in South Texas. And I've been tempted to go across and just look at the pharmacies over there. But there's drugs over there that are not real, right? Like they're in legitimate packaging, but they're counterfeit. And that's really scary because that doesn't happen in the United States. It just doesn't happen. So our regulation's a blessing and a curse. It increases the cost of medication and the bureaucracy of it. But there is no doubt if you get a prescription in the United States, it's legit, right? It's safe if you take as prescribed. So uh, the laws vary with how drugs are made, and in the United States is very strict on that. Okay, so the United States, the drug standards are published in the United States Pharmacopoeia and the National Formulary. Okay, several laws have been enacted to protect patients from unsafe substances. Okay, so they'll ban substances, and I'll give you an example of that. And unscrupulous manufacturers and distributors. So let's talk about this. The first one, unsafe substances. So I'll just take like thalidomide, right? There used to be this drug. This is crazy. That in the or like 50s, 60s, 70s, we would give to, I think it was 50s, 60s, 1950, 1960, we would give to pregnant women for nausea. It's crazy. And it did treat their nausea, but it caused their children to be born with really, really short legs and feet, right? You've probably seen pictures of this. So just realize that medications do make it through the FDA and approval and clinical trials, and they make it onto the market, and they're not necessarily safe. So we engage in something in the United States called post-marketing surveillance, where we still survey or we're still doing surveillance on drugs even when they're on the market. Even really old drugs, they're still we're still providing surveillance on them and monitoring their efficacy and making sure they're still safe. So just because a drug made it through all the steps to make it to market doesn't mean that it stays on the market because we've made mistakes in clinical trials, or people lied in a clinical trial. That happens a lot. Not a lot, but it does happen. And so just be aware. And also bad manufacturers and distributors, right? So it certainly happened where people were making not good drugs, right? Just like people could make not good candy or potato chips, right? There's certainly actors out there that are making not great drugs, or they cut quality, or they were mixing them improperly, or the what you were buying, the dose wasn't correct, or whatever. So there is post-market surveillance, and they can be obviously pretty heavy. It could be a criminal act, but civilly fined or will pull them from the market. Okay, so a couple laws that I wouldn't spend a whole lot of time learning, but they're just kind of worth knowing. This is more like general trivia. But the Pure Food and Drugs Act, so this is in 1906, right? So basically, this is one of the earlier acts that was to protect foods and medications and alcohol, right? That from being mislabeled or being poisonous or harmful. So basically, this is like one of the more first times that the federal government stepped in and said, okay, we need to make sure that people are aware of what they're buying, okay? And then the Food, Drugs, and Cosmetic Act, right? It required drug makers to include warnings about habit-forming substances and possible side effects. Okay. Um, this has been a slow catch on because for a long time, like cigarette, tobacco, nicotine, stuff like that. The Harrison Narcotics Act, okay, regulated import, manufacture, prescription, and sale of several non-narcotic drugs and cocaine, opium, and other derivatives. Okay. Uh, I will say that cocaine and opium, interestingly, are prescription. We use cocaine in nose and throat surgery, and actually you can use it inside the eye as well. Um, so, not my opinion. Okay, cocaine is a legitimate medication that is abused, and it's derived from a plant. And same thing with opium. Opium is the original morphine. So morphine is derived from opium. It comes from a flower, the opium plant. And so, uh, like in the Middle East, they still grow opium and chew on the plant. And so, for its analgesic properties, and just be aware that you know. You can't do that in the United States now, but these drugs are still have legitimate medical uses. Okay, so the Narcotic Control Act, so that this increased the penalties for violation of the Harrison Narcotics Act, and it made heroin and marijuana illegal. Not Hunter's opinion. Okay, but marijuana is illegal according to the federal government. Okay, and it's actually a Schedule One controlled substance. I'm going to talk about what that means on the coming slides. So I don't care what you think about marijuana. It's not my opinion. It's illegal. So if you see it, okay, don't take it up with me. Take it up with your Congress. Heroin also obviously illegal. So what does this mean? These drugs have no, according to the government, they have no legitimate medical use. The federal government, they have no legitimate medical use. Not my opinion. Now, this is the more important one, the Controlled Substances Act. So this is a pretty big package of legislation, and what it does is it labels drugs based on their abuse potential. Okay, and so it it requires drug manufacturers and distributors and physicians, right, to register these drugs and to know how we're storing them and distributing them and the process of buying them, right? And you have to keep records for when you're buying like controlled substances like fentanyl or Dilaudid or morphine or something like that. And obviously, there's very hefty penalties if you don't comply. And I don't need you to memorize this per se, but it's worth knowing. You've probably heard, oh, that's a controlled substance. What does that mean? Okay, I'm glad you asked. Um, we'll work our way up, okay? So what they're saying is the more likely a substance is to be abused, the higher the control, the higher the schedule, okay? So here's the weird nomenclature on this. Like uh, codeine is a Schedule 5, but it's really but they'll call it like a C4 or C5, okay? So just know that they schedule. So even though it's called a scheduled drug, they use a C in front. So I don't know why they did that. I didn't come up with it. Okay, so drugs in this category, C2 through C5, have acceptable medical uses, but they all have potential for abuse. Okay, so a C5, the lowest of the list, the least amount of abuse potential, codeine. Okay, codeine is a pre-prodrug, right? So it has to be, or it's actually just a prodrug. Actually, no, it's a pre-prodrug. So it has to be converted several times to make its way to morphine, okay, in the liver. Cough syrup with codeine would be a C5, okay? Now, other medications that are C4, like Valium, Xanax, right? These are benzodiazepine, phentermine, it's a stimulant. These still have legitimate medical uses, but they take more. There's more regulation on them. Okay, C3s, like anabolic steroids, like testosterone. Testosterone has a legitimate medical use for hypogonadism, right? But it can also be abused by bodybuilders for abuse. It could be abused, okay? And then a C2. So this is the highest level, right, of acceptable medical use, but it has the highest potential for abuse. So morphine, oxycodone, and methamphetamine. What? Methamphetamine has legitimate medical use? It does. It's called digoxin is the trade name. And so basically what it is it's used for ADHD, narcolepsy, and to treat obesity. It's not used very often, but it is a legitimate medication that's used in the United States, right? Amphetamine, right? Amphetamine salts, Adderall, very similar to methamphetamine minus the methyl group, right? So very similar. And that's also a C2. Now, this is the interesting group, the C1s. So ecstasy, heroin, LSD, marijuana, PCP. As far as the federal government thinks, there is no legitimate medical use for these. So just be aware Marijuana does fall on that list, and that throws students off, and they get all emotional about it. I didn't come up with it, okay? I don't really care either. So, manufacturing related regulations. So, I don't really have a lot to add on this. For a drug to carry a USP label, right? The United States Pharmacopoeia label, the amount of active ingredient must be within 95 to 105% of the stated label. Okay, so it's 100% plus or minus 5%. And so what that means is, remember me talking about vitamins that'll say they're USP recognized? They're saying that, like, when you buy vitamin D3 at or zinc at 50, I think it's micrograms, maybe it's milligrams, it doesn't matter, but zinc at 50 milligrams, that you're actually buying actual zinc at that concentration, because certain vitamins are considered food supplements and not medications, and so they're not as regulated as medications. So what this means is, if you see this USP label, right? If it says zinc USP, right? It's legit. It's very legit. Okay, what you're buying is what you're buying. So the Food and Drug Administration, these people do a lot of approval of drugs. The Drug Enforcement Agency sounds exactly like what they do. They enforce drug laws, including illegal drugs, prescription drugs. These are the people that go after doctors and paramedics that abuse narcotics and, buy and sell it or something weird like that. So just realize that these people do exist. They do come after paramedics and EMTs. I've heard of stories of this happening. In fact, I know a guy that has a pending case right now. I won't talk much about that, but because this, a paramedic. I don't know if he's settled or not, but anyways, Public Health Service and the FTC. So the federal what FTC? So the Federal Trade Commission protects consumers from federal trade crimes. So like fraud or like deception or something like that, especially of publicly traded companies, they'll go after basically bad actors. Okay, and so basically, if a pharmacy company lied in their clinical trials, or misled consumers, then they're probably gonna have the FTC come after them. Okay, with the part of the inspector general, and the weight of the federal government's coming down on big pharma if you lie. We're seeing this right now in the oxycodone cases, or the oxycontin cases. With, I think it was Bayer who was can't remember the company that they paid like in the billions and billions of dollars for lying about oxycontin and its addictive potentials. They lied on the marketing, and obviously they caused a lot of death from overdose. So just be aware. You get in trouble for that. So from the time that a scientist says, "Oh wow, we should create this drug," to the time it's on the market, it takes years. And that process is called R&D, research and development, and it's very expensive. And so it takes a long time to go through all these steps to make its way to the market. I'm going to show you what those steps look like, okay? So just realize, from concept to hitting the market, years, okay? And it's good and bad. It delays some important treatments hitting the market as soon as we'd like, but it also generally ensures that those hit the market are safe, okay? So manufacturers sometimes discover that the drug does not work as envisioned, or it's too dangerous. Or, I'll give you a really good example. The drug Viagra, sildenafil? It was originally thought, they were going to use this drug. So this is drug. So if you don't know, Viagra is used for erectile dysfunction, so it gives men erections. And so originally this drug was created for pulmonary hypertension, and which is a condition where you have your vessels in your lungs are clamped down, and it actually tends to affect women idiopathically. And so what happened was, they started giving this drug in clinical trials, and like men are like popping up with these erections, and they're like, "Oh wow, this drug works really well to give men erections." So interestingly, Viagra is used for for erectile dysfunction, to give men erections, and it's also used to treat pulmonary hypertension. Still to this day, it's still used to treat pulmonary hypertension. Very effective, actually. Okay, so just realize, when they start creating these drugs in the market, they might say, "Oh shit, that was a really dangerous drug. We ended up killing some rats or some participants or something like that," and they'll stop their research. Okay. All new drugs must go through animal studies and clinical trials in humans before approval for distribution. Who approves them for distribution? The FDA. Now, I don't need you to memorize these steps. I personally will not test you on these, but I put these on here just so you know. So phase 0 is basically so basically it starts off in clinical, like in preclinical, where they'll test it on lab animals, right? Phase zero, it'll be a very small number of healthy volunteers and patients with the disease of interest, and it's open labeled, so they know what they're getting. And then, so it gets so as you go further in the phases, I'll just simplify this. As you go further in the phases, you're going to get more people in the trial. And so we start off with a small amount of people. So if it kills some people, it's just a few, or it harms some people, it's just a few. And then it gets wider and wider. And as you go further, like in a phase three clinical trial, typically it's randomized and anonymous, right? So you might be getting placebo, which is a sugar pill, or you might be getting the medication that we're trying to take to market. So that's how that works. And then this last one is what I was telling you about, right? This is the whole post market surveillance. Okay. So after it's out on the market, we're still looking at it, we're still making sure it's safe for consumers. So drug containers should be guarded against possible theft, of course. Yeah. Uh, if controlled substances are administered, the records must be kept separate. So if you ever give it, which EMTs don't, but paramedics, if we give a controlled substance, it has to be logged. It's usually logged in several places in your chart. It's usually logged somewhere on paper. Um, and so there's several records of the medication being given. So every vial, every milligram of that substance has to be accounted for, and usually multiple parties are witness to it. So as an EMT, for example, say we're working on an ambulance, me and you. I'm the paramedic, you're the EMT. You would, if I give a patient morphine, you say I give him 5 milligrams of morphine, and you have to watch me quote waste the other 5 milligrams of morphine when I squirt it on the ground at the hospital ambulance bay. You would have to witness that. That yes, I watched Hunter waste the 5 milligrams of morphine at this time, at this date, blah 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 blah. Okay, so expired control substance must be destroyed. This is really annoying because you can't just like take a bunch of vials of expired morphine and just chunk it in the trash. It's actually a process called reverse distribution, where you have to like again a lot of paperwork, send it back to a certain company where they will destroy it, and they acknowledge that they destroyed it. So they're basically like people that get paid to destroy medication and account for the destroyal of it. Now, medications, some of them are really sensitive, and I put a picture. This is what nitrostat. This is oral nitroglycerin. It's used for chest pain. EMTs can help administer this. It is uh, it's very unstable. Nitroglycerin's unstable. Okay, so it has a short shelf life, and there's a couple considerations of it. The first one is temperature. It can't get too hot, can't get too cold. Okay. The second one is light. So when you see prescriptions that are in these dark vials like this, it's because light will break down the medication or change the form of it. Okay. Moisture. If you get too much moisture, like humidity or water in this vial, these tablets go underneath the tongue and they dissolve. So as you can imagine, they're very dry. So if they get moist, they'll expand and they can pop and they cannot work well. Okay. Shelf life, this is how long is it good for? There's medications that are good for several years, and there's medications like this one that's going to be good for only a few months. Okay. And exposure to air. So you want to make sure that the lid's back on here tightly and it's not being exposed to air. Why air? It's because there's moisture in the air, one, and two, there's oxygen in the air. And oxygen's an oxidizer. So it causes, like just like rust, right? It could cause an oxidization of the medication. So that's why. Now, just these are just some general considerations that we keep in mind with like special populations, and we'll talk. There's an entire chapter on special populations, so we'll hit this again. But in general, pregnant patients, you have to be generally aware of what you give the mother will generally pass the placenta into the child. Okay, so you have to again weigh the risk versus reward to the like to giving a 22-year-old woman a pain medication is one thing. Giving a 22-year-old woman who is 8 months pregnant a pain medication is another thing. So you really have to consider the pros and cons, and you have to consider the risk not just to the mother but to the fetus. Okay. Changes in pregnant women's body affect the way drugs are processed. It's true they have more plasma, their body works a little faster, they have a higher heart rate, their kidneys tend to get a little wrecked out a little bit more. So just something to consider. They can also have a little bit of liver issue, and that's normal. Not normal, but it's almost to be expected, right? So the FDA has what's called a pregnancy drug class that basically indicates the likelihood of causing issues for the child. So it's like A, B, C, D, and X. And if it's class X, it's absolutely contraindicated. You cannot give it. And then if it's like drug class A, B, C, or D, basically a D is like, whoa, you really shouldn't give this. Think like 10 times before you give it. And like a class, and obviously in class A, B, C, it's a little less harmful or risky. Okay, so again, there's risk versus reward. There are times where you're going to have to give pain medicines to a pregnant patient. That's fine. But you have to weigh the risk. Is it worth it? Am I going to cause more reward than risk in this case? Am I going to cause harm to this fetus? Okay. So they're saying you could delay pharmacological treatments for pregnant patients until they reach the hospital. As an EMT, generally, sure. As a paramedic, no, not really. But just be aware, as I always say, before you put something in someone's body, you need to think about 10 times. Should I really be doing this? Like, is this really going to cause? Is it going to cause harm? Am I going to help the patient? Can I justify why am I doing this? Do I know how this medication is going to work? All of that. And always, you'll see this on exams. When in doubt, contact medical control. Who's medical control? That's the doctor. Okay, so push the blame onto someone else. Be like, what? I called Doctor so and so, and he said to give the medication, so I gave it. Right? But always when in doubt, contact medical control. That's going to be the answer if they push you into a doubtful situation. Pick contact medical control. It's probably going to be the right answer. Pediatric patients. So medications affect children differently. First off, they weigh significantly less. Okay, so the doses is different. And then young infants have a reduced metabolic capacity. But interestingly, so that's infants, right? Less than a year. And so, but interestingly, children metabolize medications quicker than adults. Weird, right? So like an 8-year-old boy can chew through metabolism or fentanyl, which is a pain medication, really quickly, and I've seen this clinically, compared to a 28-year-old male. So kind of an interesting dogma. So again, infants have a reduced metabolic capacity, but children tend to have a quicker metabolization of certain drugs. Geriatric patients, who are those, right? These are older people, generally patients older than 65. Geriatric patients, their hepatic, which is their liver functions, and their GI activity tend to slow. So they could have delayed absorption and elimination. What does that mean? So when they take the medication, the time for it to pass through the GI tract and get fully absorbed could take longer than it's supposed to. One. Two, it could, if it's activated or if it plays a role with the liver, which it will, that could also delay it. Now, with that said, this delayed onset can also lead to a decreased elimination or delayed elimination. So we eliminate most drugs through the urine or through the feces. And so what happens is the kidneys could be slowed down. So the same drug that you would give me, a young guy, right? You give the same dose to someone who's 88 years old who weighs the same amount, right? That drug would likely be staying in, it's going to take longer for it to onset, and further, it's going to be floating in their system longer because their GI, everything's slowed down when we're older, right? So everything's slowed down. So as a general pathology rule, right, and really physiology rule, everything in old people is slower. So just think of it that way. And it's not my opinion, that's really the truth. Everything slows down. So older people tend to engage in something called polypharmacy. If you break down that word, it's pretty obvious what it means, right? So it's mini pharmacy. So they take several medications, and you'll see this on the ambulance, and you'll be astounded when you have to put in all their medications in your chart, and you're like, holy cow, they take 15 medications, 15 prescription medications. It's very like, whoa. So just be aware, they take a lot of medications, and sometimes these medications will interact not only with each other, but with medications that we might administer. The perfect example, someone taking Cialis, again, for erectile dysfunction, a male, and you, as an EMT, decide to give them nitroglycerin, right? That would cause harm, could be fatal, okay? So there's interesting legislation happening on this as we speak. But you are legally, morally, and ethically responsible for each drug that you administer, okay? What does that mean? That means that legally you are responsible, but the physician told me to. No, 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 no. You are still legally responsible for this, okay? And so there's nurses, and this is very scary. I won't go into the political side of it or the criminal justice side of it, but that are being criminally charged for medication errors, right? The nurse that has killed patients with a true accidental medication error, and they're facing prison time. And not only that, the civil penalty, right? The monetary penalty of it. So just be aware, you're still responsible. At the end of the day, it's your problem, okay? Drug administration must be safe and therapeutically effective, sure. So you would want to keep a field guide, whether that's on your computer or on your phone or in print to reference. Okay. Uh, So there's drugs that have different classifications, obviously. So there's a bunch of different brands of antihistamine. There's a bunch of different, you know, non-steroidal anti-inflammatory drugs, right? So there's a bunch of different classifications of drugs, okay? And so they tend to be classified into three categories: the body system, the class of the agent, and the mechanism of action. So let's talk about that. I want to talk about something first. This is a general dogma of pharmacology to lay the foundation as we move forward, okay? So let's zoom in right here. Let me use this color. So this is a synapse. Okay, so this is the end of a nerve right here. Okay, and this is the start of something else. Okay, let's just say it's another synapse or it's another neuron or it's a muscle or something. Okay, in this case, it's in the brain. And so what happens is in pharmacology, we typically are blocking a receptor or we're acting on a receptor. Generally, that's generally what happens more often than not. So, I'll just give an example of like amphetamine, okay, like Adderall. So, you know, what happens with Adderall is it increases the release of the vesicles at the end of the synapse. So it releases dopamine and norepinephrine, okay? And so this will be floating around in the synapse, and there's receptors down here that are like, oh wow, there's extra dopamine and epinephrine. Great. So let's have the effects of dopamine and epinephrine, right? Increased heart rate, maybe some euphoria, decreased appetite, increased focus, right? So that's one way that would work. Now, interestingly, there like cocaine very and amphetamine, right? Same way. The drug works in another way. It inhibits reuptake of a medication. So this norepinephrine's floating around. And it's like, okay, I did my job. I'm going to go back home. Well, what happens is there are drugs that'll say this net, right? This little molecule called net that will inhibit that to where it's like, no, norepinephrine, you're actually going to stay floating around the synapse and you're going to work longer than you want to. And so that's one way that we'll do that. So what am I telling you? I'm telling you that the majority of pharmacology works in one of two ways, in either agonist or antagonistic properties. And so this is a real quick example of that, but I'll draw this out for you because you absolutely have to be able to understand this and explain this. And I've talked about this in pathophysiology. So this is a cell, right? Some cell. And this cell has receptors on it, okay? And so what happens is, let's just say this is I don't know. I'm trying to think of a drug that does it this way. We'll just say that this is because it doesn't really work that way. Brain fart. We'll just say that it's we'll just say that this is a neuron for pain. Okay. So let's just say that uh, this is the receptor to this, right? And so what happens is when something in the blood comes up to this receptor and binds to this receptor, and it binds it perfectly. They're the same size, they're the same shape, they're the same match, they shake hands. What happens is it'll send a signal down into the cell to say, hey, do work. Okay? And so what happens is in pharmacology, this action I just described is called an agonist. Okay? So an agonist. So an agonist binds to a receptor and tells the cell to do work. An agonist binds to a receptor and tells the cell, hey, cell, do work. And so that's one way to think about it. Now, another way that this can happen is you could have the same receptor, and then you could have a medication that floats around and binds to this receptor perfectly, but it doesn't tell the cell to do work, it just blocks the receptor. And so what happens is this little guy, right? It can't bind to that receptor because it's already bound. And so what is this green guy called? It's called an antagonist. An antagonist. An example of a very classic antagonist is Narcan. So you've probably heard of this drug, naloxone, right? So basically what this drug does is if someone's overdosing on fentanyl or Dilaudid or morphine or oxycodone or something like that, Percocet, you administer this medication and it goes into the blood and it finds these receptors and it just blocks all the opioid receptors to where when the opioid floating around in the blood, it can't bind. So this is how we reverse narcotic overdoses. So antagonist or Narcan, that would be an example, and an agonist would be something like morphine, heroin, Dilaudid. Uh, some of the actually a lot of the EMT drugs we don't work on receptors; they work differently. But anyways, those are examples. Okay, very important concept to understand. There's videos all over YouTube of how that works. Okay, so we'll talk about some CNS drugs. Hang with me. So the these drugs are kind of scary. I would say scary because when you start messing with chemicals within the brain, right, you're going to get some pretty drastic effects sometimes, right? So uh, the CNS, right, the nervous system, right, is the principal control system of the body, okay, and the uh, uh, the peripheral nervous system includes all the nervous tissue outside of the central nervous system. So what's the central nervous system? It's the brain and spinal cord. The peripheral nervous system is pretty much not the brain and spinal cord, but the peripheral nerves. Okay, so the peripheral nervous system does contain the autonomic nervous system. So autonomic, just like an automatic transmission, right? It's just automatic, so it kind of works on its own. Okay. The autonomic nervous system is divided into the sympathetic and the parasympathetic nervous system. We've talked about this a lot. So remember, the sympathetic nervous system is it's your fight or flight, right? So if you have to fight a bear, right, you got to fight. You want all that adrenaline, all that epinephrine, all that norepinephrine and dopamine to dump, right? And so what's going to happen? Your eyes are going to dilate so you can get as much light as possible, so you can see as much as possible. Your heart rate's going to increase your blood flows to your muscle. You're going to have increased mental acuity, right? Those are the big things that will happen, right? You might get a little bronchodilation, but that's right. So I always think, okay, if I'm going to fight a bear, what's going to happen to my body? As opposed to the parasympathetic nervous system, of course, this is the rest and digest. So we tend to get uh, pupillary constriction. We tend to get salivation of the mouth because remember, digest as need to eat. We tend to get quicker movement of the guts, right? You could get slower heart rate, right? And so there are medications that we give that act on each of those, right? Sympathetic, again, cocaine. It's a sympatholytic, right? So it acts on the sympathetic nervous system. Parasympathetic, atropine. Well, it blocks the parasympathetic nervous system, but parasympathetic that acts on it. This is interesting. Fertilizers like organic organophosphates, right? Certain substances, especially used in farming, they tend to overstimulate the parasympathetic nervous system. Nerve agents, right? Sarin, stuff like that. It overstimulates mustard gas, tends to overstimulate the parasympathetic nervous system. Okay. Now, there there are hormones, right? And these really kind of, well, okay. There are hormones that are released by the sympathetic system and stimulation and act on hormone receptors. Okay. Well, I hate that they use the word hormones because hormones are actually intranuclear, but that's fine. But the they've divided these into different classes. And you've heard me say a lot, what's the treatment for asthma? I say, oh, well, it's a beta 2 agonist, okay? So albuterol, right, acts on beta 2. So it binds to that little beta receptor, and so it tells it, hey, beta 2, do your work. And then we get these expected effects. So, like, I could direct your attention right here to beta 2. So when beta 2 is stimulated by albuterol, an EMT basic drug, the lungs will dilate. They'll have vasodilation, or I'm sorry, bronchodilation. We could get blood vessel actually it constricts. Blood vessels would constrict. Um, you would slow down peristalsis, sure. But the big thing is with beta 2, you get lung bronchodilation. And so why am I pointing this out? Sometimes that these drugs are classified into this. Now, I should point out that not the drugs don't have to be exclusive. So there's certainly drugs that will act on beta 1, beta 2, alpha 1, alpha 2, right? Or beta 1, well, really all of them. So like epinephrine, for example, an EMT basic drug. It certainly acts on beta 2, acts on beta 1, and acts on alpha 1 as well. So just be aware directly, and then it certainly has effects on alpha 2. But just be aware, okay? I'm just pointing some things that we have these things called adrenergic receptors that cause a response at target organs. Now, I will say, if you get lost, beta 2 is because we have two lungs. Beta 1, you have one heart. One way to remember that. Say that again. Beta 2, like a beta 2 agonist, like albuterol, right? For asthma, that's two lungs. Beta 1, one heart. Okay, sympathomimetics, right? And I said sympatholytics, that's not correct earlier for like cocaine, it's a sympathomimetic. Um, that's cocaine, amphetamines, methamphetamine, ephedrine, stuff like that, dopamine. Okay? Sympatholytics inhibit the sympathetic nervous system, and these are also known as antiadrenergics. You don't need to know about those. Those are pretty rare, and we don't carry those on the ambulance. Okay, so I just talked about this. An antagonist, so you have to know these definitions. It's coming up on a test near you, right? An antagonist will counter out the action of something else. So what's an example of an antagonist? It binds to a receptor on the cell and it blocks other stuff from telling that cell to do its job. The example I give you is Narcan, naloxone, right? To use in narcotic overdoses. An agonist will bind to a receptor and cause a response. What's an example of an agonist? A beta 2 agonist, like albuterol. Okay. Now we do have these things called beta blockers. We do carry these in the ambulance. These are paramedic drugs, but basically we can block this whole beta 1, beta 2 stuff. Um, and so if someone has like a fast heart rate, or we want to keep their heart rate slow or something, there's a lot of reasons why. We can give them something called a beta blocker. I'll just have you know these drugs end in LOL. So like propranolol, labetalol, metoprolol, they end in LOL. Okay. Now, beta 2 selective drugs cause bronchodilation with little effect on the heart. Pretty little effect on the heart. I would agree with that. Now, with that said, albuterol does cause tachycardia, and I want y'all to know that because it's true. Not my opinion. Now, this parasympathomimetics, right? These are the drugs that overactivate. So they're agonists that overactivate the parasympathetic nervous system. So weirdly and annoyingly, these have two names. They're also called cholinergic drugs. Okay. So if excess cholinergics are present, you'll present with something called sludgem. So what does this stand for? I'm not going to write this out. My handwriting's too bad for it, but I'll say it twice. So follow along here. Excuse me. Salivation, lacrimation. So salivation, right? So a lot of spit in the mouth. Lacrimation, tearing of the eyes. Urination, obvious. Defecation, obvious. Gastroemesis, upset. And then I want to say it's meiosis, which would be dilation of the eye. Oh, wait, no, it'd be constriction. So that is sludgem. Salivation, lacrimation, urination, defecation, gastroemesis, upset. Okay? Maybe it's my drysis. And I gotta look this up. This one will bug me. Sorry, guys. Hold on. Cue the Jeopardy music. It's meiosis. I was correct the first time. Okay, so moving forward, um, we do give a drug called. So that's and I'll tell you the most common cause of this: the parasympathomimetics, right, or cholinergics. We do give these medications in pharmacology, right? Like what's wrong with my pen? Um, Sorry, jeez. Okay, so this would be organophosphates. So watch in the vignette for the farmer who was putting out fertilizer in the field or was standing underneath the crop duster, and now he has salivation, lacrimation, urination, defecation, gastroemesis, upset. Okay, and meiosis. So parasympatholytics, right? The medication that we use for this is atropine. You don't need to memorize these right now, but it's a drug carried on the ambulance that we give when people have slow heart rates, basically. Because think about it: if you block the parasympathetic nervous system, slows the heart rate. If you block the parasympathetic nervous system, you're going to increase the heart rate because you're blocking the thing that slows down the heart rate. So that's an example of that. These are also called anticholinergics. Analgesics, okay? So these provide analgesia, right? And they relieve pain. Medications like analgesic could be the ones I keep naming: morphine, fentanyl, Dilaudid, Toradol, Tramadol. Uh, the list goes on and on and on. Okay, very popular drugs. Opioid agonist. So these are straight up from opium. So morphine, Dilaudid, Oxycontin, Vicodin. Those are really more synthetic, but drugs that are opium based, morphine, codeine, opium based. So those are all examples. Now, a good thing to know is these are CNS depressants. So you heard here, folks. What's the signs of an opioid overdose? Okay, first one we know is they stop breathing or they have so depresses the central nervous system. So they'll have a decreased respiratory rate, and then also they will have pinpoint pupils. Very important that you know that. So non-opioid agonist. This is like Tylenol would be an example of this. And they could treat pain. Aspirin. Okay. And so what they do is they alter the production of these things that tell us that we're having pain, like prostaglandins and cyclooxygenase. So I just draw this out for you. It's kind of interesting. You may not know this. So let's just say this is a cell. Well, some cells. And so basically within here is this thing called arachidonic acid. And so when this cell gets hurt, right, trauma, whatever, it opens up and it releases stuff called arachidonic acid that goes down this pathway that creates prostaglandin and cyclooxygenase. Well, what does aspirin do? It inhibits the pathway from arachidonic acid, which is released when there's cellular injury, to make its way down to prostaglandins and cyclooxygenase that create the pain response and the inflammatory process. So that's an example. So salicylate, right, or acetyl salicylic acid, right, aspirin, very common. We carry this on ambulances. EMT basics give it. You'll know a lot about this before this course ends. NSAIDs like ibuprofen, naproxen, meloxicam, and then paraminophenol derivatives, right? So acetaminophen, okay, this Tylenol, okay. So opioid antagonists, we've talked about this, Narcan, which is also known as naloxone. So what happens is it'll bind to the receptor and it'll inhibit the morphine and stuff from morphine will come to that cell, but it bounces off and it can't really tell the cell to do its job because it's blocked. It's already bound by Narcan. Okay. Interestingly, we have opioid agonist antagonists. An example of this would be Nubane. We don't carry this drug anymore in EMS, but basically, this is really weird. It acts on the opioid receptors, but it also blocks opioid receptors at the same time. So they used to use this quite a bit in the early thousands. They found it was kind of dangerous. It's not used very often anymore. They could also use this in people that struggle with addiction. So we have anti-anxiety, sedative, and hypnotic drugs. Okay, so these fall into a very special class. Okay, I'll explain. So these could help a patient sleep through a medical procedure by producing, hypnosis. Okay, sedation. And so there's different classes of drugs. Benzodiazepines. You've probably heard of Xanax before, right? That's it. Ativan, Valium, Versed, right? Lorazepam, Midazolam. These tend to end in PAM or LAM. So benzodiazepines. And then barbiturates. These are very dangerous. You don't see these in the United States anymore. They're common overseas though. So the example of this would be phenobarbital. This very, very dangerous drug. It has it'll cause CNS depression and it won't stop. So it's very, very dangerous. You don't see this very often. But these act very similarly. Just know benzodiazepines are a little bit safer. Still dangerous though. Opioid agonist. So like again, narcotics like morphine or fentanyl, we can produce sedation and hypnosis with those drugs. Non-barbiturate hypnotics. So these would be like Ambien, right? It's a sleeping pill. Zolpidem. Okay. Dissociative anesthetic agents. So this would be ketamine, right? Ketamine causes dissociative amnesia. Okay. So what's dissociative? This is kind of like what would be described as an out-of-body experience. So I've actually dosed patients with ketamine before where they've told me afterwards that they felt like they were floating on top of their body, kind of like looking down third person at themselves. And they don't remember, they knew they were in pain, but they didn't process that they were in pain. It's kind of an out-of-body experience if you dose it right. Great drug, love ketamine, it's cool. Anticonvulsants, so it sounds like what it sounds like, right? These are drugs that make you not convulse, okay? So we use these for seizures, like Keppra and phenytoin. Those are some of them. And then we also still use like benzodiazepines like lorazepam to treat acute seizures, Versed, midazolam, right? So but drugs like phenytoin and Keppra and stuff like that, right? They believe to work. Well, we know they inhibit influx of sodium into the cells, and the sodium can't come into the cell. It can't reach the action potential, so the cell just kind of stays there and idle. So that's how that works. Okay, and so that's what I just described here, right? It decreases the cell's capability to depolarize and propagate the seizures. Stimulants. So this is medications like again, Adderall is a stimulant. Interesting. Let me tell you something. Students get this wrong. It drives me nuts. Caffeine is not a stimulant by the medical terms. It's not a stimulant. It's an adenosine receptor antagonist. Adenosine makes us feel tired, and so when we block adenosine, we feel less tired. Okay, caffeine, and it's not a safe drug necessarily, but it's not a technical stimulant. Okay, now what happens is when someone takes, again, like Adderall, or amphetamine salts, amphetamine, you increase the excitatory neurotransmitters like dopamine, epinephrine, or epinephrine, while you kind of therefore have a decreased ratio of inhibitory neurotransmitters like GABA. Okay, and so that's what I just said. And it increases wakefulness and awareness, and it can create euphoria. But high doses of this will cause irritability, anxiousness, nervousness, tremors, headaches, tachycardia, which is a fast heart rate, high blood pressure, right? Delusions, or it would really not be delusions, delirium. Okay, so I ran a lady once who was overdosed on methamphetamines, and she thought she was Jesus Christ, and she's fighting and pulling against the handcuffs. It's actually very scary. It can cause seizures. If someone overdoses on amphetamine or cocaine or something like that, they can have seizures. So depressants will slow brain activity. These are the same ones I keep telling you about. So we use these to prescribe to treat anxiety, muscle tension. Sometimes it can be used for pain. Insomnia. Insomnia is someone who has a hard time. It's a sleep disorder to where they have trouble falling asleep and or staying asleep. Stress, panic attacks, and seizures. So these have a very wide use. We use these for a lot of things, but depressants slow things down. What's a really common depressant that's over the counter? Kidding. It's alcohol, right? ETOH, right? Ethanol. So alcohol is a depressant. Okay. So examples of these would be lorazepam, which is the trade name is Ativan; diazepam, trade name is Valium; alprazolam, trade name is Xanax; zolpidem tartrate, Ambien. So this is not a benzodiazepine, but it's very similar. And so basically, this is a sleep drug. Okay, so this helps people sleep. All of these have huge addictive properties. Very addictive. Very, very addictive. Really, so do stimulants. Very addictive as well. So psychotherapeutic drugs. So sometimes we use drugs to block certain receptors in the brain for different reasons. And so if someone has too much dopamine, they can have a condition called schizophrenia. And so we'll give them drugs called antipsychotics that will block dopamine receptors in the brain, so they're kind of less manic. Okay, that's how we treat schizophrenia right now. Conversely, we think in depression that they may not have enough dopamine or norepinephrine, or serotonin. So what we'll do is we will increase the amount that sits down there in that synapse, and so that's why that's kind of like what I was showing you earlier with the drawing that I put on there. That's the kind of the general dogma. Do we want to increase the amount of drug, or do we want to decrease it, or do we just want to block the receptors, right? That's one of the general dogmas of pharmacology. So we have drugs like SSRIs, right? So this is a selective serotonin reuptake inhibitor. This is used a lot in depression. These are, you don't memorize these guys, but a monoamine oxidase inhibitor. This is used to treat Parkinson's disease. So this would increase the amount of dopamine in the brain. Okay. Tricyclic antidepressants. This is also obviously used for depression. They're TCAs are danger, like amitriptyline would be an example. These are I'm misspelling this. If someone overdoses on these, they're very bad. It's very lethal. The way they die is really pretty tragic. So, anyways, just be aware. We're getting to the end of this, okay? So hang with me. But basically, there's also obviously drugs that affect the cardiovascular system. So we're gonna have effects on the heart. It can be positive or negative. So chronotropic means time, just like chrono means time. Why can't I spell today? Time. Inotropic means the contractility, and dromotropic is the speed of the conduction. You don't need to memorize that. I'm just pointing that out. So we have drugs that we might just want to speed up the heart rate itself, the timing of the heart. And then we have drugs where we might want to speed up the timing of the heart and how fast it's and how strong it's contracting, right? And so there's different cardiac drugs out there that will do one or several things, or there's a mixture that'll have both chronotropic and inotropic effects. Epinephrine is an example that's all three of these. It increases all three of those. Epinephrine is both increases chronotropy, inotropy, dromotropy of the heart, plasmatropy, right? So that's one way to look at that. Cardiac glycosides, this is a really annoying drug called digoxin, and we give this to patients in heart failure. So basically what happens is, I'm not going to explain how this happens actually, it makes the heart beat more effectively. We'll just say that. It's very complicated. So, and you don't need to know how, so I'm not trying to fill your head with information you don't need to know. So that's one way we can treat the heart. The other way is we have antiarrhythmic medications. So obviously arrhythmia of the heart can be very fatal. So we do this in several ways. So we have sodium channel blockers like lidocaine, okay? Beta blockers, again, like metoprolol. Potassium channel blockers like amiodarone. And calcium channel blockers like diltiazem. And you're like, God, Hunter, don't flex on us. I'm not really trying to flex. These are all paramedic drugs, actually. So when you go to paramedic school, these are all drugs you're going to get to learn. So that's important because paramedics fix arrhythmia. It's a big part of what we do. Antihypertensive, sounds like what it sounds like, right? Anti-high blood pressure. So these work in several different ways. Sometimes, like spirolactone specifically, or even Lasix or hydrochlorothiazide, right? We will reduce the amount of water in the blood. So we kind of inhibit, like we'll tell the body, pee out water and salt. So that'll decrease the amount that's floating around in the pump. So hopefully it'll lower their blood pressure a little bit. That's one way we do that. We also have vasodilators. So we could give drugs like cardine or something like that. Cardipine would be an example. Sympathetic blocking agents diminish the effect of beta stimulation. Yeah. An example of this would be beta blockers can lower blood, like labetalol would be an example of that. Okay. And then we have ACE inhibitors, angiotensin converting enzyme inhibitors. So, and basically what these do is these inhibit the RAS system, renin-angiotensin-aldosterone system. And so basically, it's complicated, but the kidneys can say, hey, we have low blood pressure, and they can activate this system called ACE that I don't want to explain. You don't need to know how this works, guys. So just know that there's different ways that we can lower blood pressure, okay? So anticoagulants. So think about that word, anticoagulation. Coagulation is clots. So anti-clotting drugs, okay? Fibrinolytics. So fibrin is a component of blood clots. So to lyse is to cut. So break down that word. We're going to cut up some fibrin that was causing clots, okay? And then blood components. So I'll give you an example. An anticoagulant would be like warfarin would be an example. It's a very common one. Fibrinolytics, this would be like TPA. So, and then blood components, obviously that's like whole blood, red blood cells, something like that. So, antiplatelet agents interfere with aggregation of platelets. What's an example of that? Aspirin. Aspirin interferes with platelet aggregation, okay? So what are platelets? If this is a vessel, and these are platelets. Okay, let's say this is a vessel, and here's a thrombus, okay? Well, what happens is platelets are floating around in the blood, and they come up here, and they're like, yum, blood clot, and they start attaching to the blood clot, and then they're like, oh, hey, platelets, come join. So then more platelets will join. And as more platelets join, you end up with a complete occlusion of this vessel, and that's how heart attacks can happen. So what happens is when we give aspirin, what you do is you inhibit these platelets they're still there, but they can't bind to other platelets. So they can't aggregate and kind of block off the highway to cause a complete occlusion of this vessel. So that's how aspirin works. and that's why we give it in chest pain. Anticoagulant drugs work against coagulation, prevent formation of thrombi. So again, warfarin is a really heparin are examples of that. Okay, fibrinolytic agents. So this is like TPA. So this is drugs that we give in stroke. It's a very expensive drug, and basically you give it through the IV, and it'll go in there and it'll find little blood clots, and it'll literally just start chewing at them, and hopefully chew them apart to allow blood flow to go back in through that area to restore function in like a stroke, or even sometimes we use this in heart attack as well. So drugs affecting the respiratory system. Remember, oxygen is a medication. Again, I told you this, I think, yesterday. Oxygen is a medication and has appropriate and inappropriate uses and side effects. So again, everything has a therapeutic or a toxic level. Okay. Many respiratory emergency treatments use sympathomimetic medications. What does that mean? A lot of times in respiratory emergencies, what we do is we amp up the sympathetic nervous system, right? Because it will cause bronchodilation. Again, if you're going to fight a bear, do you want to open up all your bronchi and let all the air in so you have as much air as possible to fight? Of course you do. So we take advantage of that and we stimulate the sympathetic nervous system with drugs called sympathomimetics. Okay, so albuterol is a sympathomimetic medication. Albuterol, also known as a beta 2 agonist. Xanthines, these are annoying. These we don't use these anymore, but these are drugs that work on almost like caffeine receptors to stimulate the nervous system a little bit. Okay, don't need to know a lot about those because they're not used anymore in emergency medicine. They've been replaced. Corticosteroids. So something I want you to know that corticosteroids try to mimic the naturally occurring substance in our body called cortisol. And cortisol is a medication that's induced under times of stress. And so what happens is when you're under stress, your body will say, just hold on to everything you can to don't waste stuff. And so if you know anything about white blood cells, they take a lot of stuff to make. And so what happens is when you give someone corticosteroids like dexamethasone or methylprednisolone or prednisone or whatever, it tells the cells hold on to the stuff that we need to make white blood cells, specifically T cells. And so that's kind of the idea of corticosteroids is they suppress inflammatory response. So basically, you knock down the immune system when you give corticosteroids because sometimes the immune system is the problem in cases like asthma and anaphylaxis. That's the problem. It's the immune system that is creating those problems for us. Okay. So drugs that affect the pancreas. Yeah. So there's a variety of hypoglycemic medications that are available. Okay. Glucagon would be an example. Oral glucose would be another example. Some act on the pancreas directly. True. An example of this would be like, metformin a little bit. That's probably an example that's pretty common. Okay, sulfonylureas, that's a even better example. These sulfonylureas, this is like a prescription drug that people take by mouth, and basically what it does is it tells the beta cells in the pancreas. Remember, beta cells produce insulin. It tells them release more insulin, release it quicker, faster, be better at your job. So that's what sulfonylureas do. So insulin sensitivity is increased by oral hypoglycemic agents. Yes. Wait, insulin sensitivity is increased by oral hypoglycemic agents. Well, I'm having a hard time breaking that down. Insulin sensitivity is increased by oral glycemic agents. Okay. Yeah, I mean, I don't have anything to add on that. Maybe it's kind of obvious, so that's why I struggle with that. My apologies. So drugs affecting the immunological system. So immunosuppressant medications are often prescribed to patients so if someone has an organ transplant, it's never going to be a perfect match, even usually amongst twins. So what happens is you have to knock down their immune system to where their body doesn't attack this foreign stuff like a new kidney that's really not theirs. So we do that. We'll knock down their immune system intentionally. And also if they have an autoimmune disease, so drugs or conditions like lupus or myasthenia gravis or multiple sclerosis or, the list goes on and on of autoimmune diseases. So I will tell you, because I just told you this, the most common way this is done is steroids. We'll give corticosteroids in high doses for long periods to knock down the immune system. So just watch for that. If the patient tells you, I've had a kidney transplant, they're immunocompromised, right? They're immunosuppressed. Okay. Same thing if they're usually, I mean, not always, but if they're like have an autoimmune condition like lupus or something like that as well. So uh, basically, yeah, that's what I just talked about. Vitamins and minerals, be careful. Just because a little's good doesn't mean more is better. You can't, I mean, it's very well documented. There's toxicity of vitamins and minerals. Okay. You can take too much iron, obviously, or calcium or zinc or vitamin C or whatever. Okay. So, uh, this is obvious that we use these in cellular functions, but thiamine which is also known as vitamin B1, is probably the most commonly used in pre-hospital environment. There's a condition called Wernicke-Korsakoff syndrome, where someone's malnourished, and we were to administer them glucose, then they could have. We talked about this, by the way, but they could have cerebral edema and long-term neurological effects that affects their memory. So yeah, we give thiamine, which is also known as vitamin B1. Okay, fluids and electrolytes, we've talked about that as well. We're not going to talk about that. So we're getting towards the end. So uh, be aware that medications are in different formularies, right? So there's IV form of Tylenol, and there's suppository forms of Tylenol, and there's oral forms of Tylenol, right? So they're different forms of drugs, and we have to administer them properly, and the dosage can certainly change based on how we're going to administer it, right? So just be aware of that. And the way that medications are designed is we the dose and how it's administered and how it's created and what it's bound to. We use this to see to anticipate how quick it's going to be released into the bloodstream and how quick it's going to be eliminated and the duration of action and the onset of action and all those other things. Okay, so I don't need to explain to you the difference between a capsule. Well, I mean, I guess I can, but like uh, this looks like a suppository to me. Okay, we're starting at the bottom. So the suppository is a medication that goes in the rectum. Okay, Tylenol would be an example of that. Uh, these look like tablets. These would be little capsules, and these would be little pills. So obviously, there's solutions, suspensions, tinctures, spirits, elixirs, syrups, emulsions. Don't need to know all of those. The intricacies of those are not important right now. Now, we do use this a lot. This is called a meter dose inhaler. These are also called MD, whoops, MDI. It's a meter dose inhaler. And so what happens is this is albuterol, probably. And so you shake this. So the instructions this is you shake it well, and then you'll have the patient put their lips around this. They will depress the canister. It will release a meter dose of substance. And as it's released, the patient will take all their breath out, put their lips around it, inhale in, hold their breath for a few seconds, and then they can let out. That's an MDI. That's how that works. Okay. These are very effective. The literature says that these are just as effective as nebulized medications. These are very common. A lot of patients have these. So we will have these in class. We have some practice ones that will show you how to properly administer these to patients. Okay. Topical medication. So topical means it goes onto the skin. So medications like nitroglycerin, the one that I showed you earlier that we take for chest pain, it can be administered by the mouth. It can be sprayed and go underneath the tongue. That's sublingual. It can be sprayed in the mouth. That's different. Or it can also be applied on the skin, and it's weird. It's measured by the inch. Okay, so that's medication that's administered on the skin. Topical. Transcutaneous, the best example I could give for you this is a medication like fentanyl. So patients that have chronic pain or that are like hospice patients, they'll wear a patch. Another example that you've probably seen before is nicotine. The good thing about this is it's in a constant administration. So, when you take something by mouth, right, it's kind of like, oh, you give it and it's good and it wears off, and you give it and it's good and it wears off, and you give it and it's good and it wears off, right? And it goes like this. But when you give something by patch, it kind of just stays, it's a more smooth ride. And then so you take it off before the patch runs out and you replace the patch. So a nice thing about transdermal is it's designed to go through the skin, but it's a more smooth ride for the patient. There's not these ups and downs. Now, with that said as well, something that's important about this is this stuff will go straight through your skin, okay? Your skin, the provider's skin. So be careful taking off someone's fentanyl patch without a glove, right? Or, something like that. So generally, if you do take off a patch, it should be put onto like some plastic or something or folded up on itself. Just be careful. This can go through your skin. It can also go through your gloves if they're not properly rated. So just be aware that this can go through. And there's been stories of this happening to EMS providers that took off a fentanyl patch or a nitro patch or a nicotine patch, something like that, and they're getting exposed to the medication. So be very mindful of that when you're taking these off. Why am I telling you this story? I ran a call not too long ago. This is back when I was on the truck. That me and Jeff Schwartz actually ran this lady, and so she was like all acting all crazy and real drowsy and somnolent and obtunded, and we were like, "What's wrong with her?" And so we did a full body exam, and we happened to look at her back. She had like 6 fentanyl patches on her back. You're supposed to have one. Okay, so be aware that sometimes patients don't realize when you put a new patch on, you take the old patch off. She didn't realize that. So she's getting this huge dose of fentanyl, and so of course she was acting wrong because she was overdosing on fentanyl. Gels, that we carry this on the ambulance. So this is just straight up oral glucose. It's 15 grams. And so basically what you do is you instruct, and we'll show you this in class, you instruct the patient to put this in their buccal membranes up on their gums and just let it sit there for a second. It'll absorb very quickly and bypass the liver. And so it's absorbed really quickly. And so we give this to patients with low blood sugar. The lemon one's the best flavored. Now, gases, I mean, I don't need to describe that, but there are ambulances that still do carry, not that I know of, but that will still carry nitrous oxide, laughing gas for pain. Excuse me. Wonderful drug, by the way, for pain. Wonderful drug. I wish more ambulances would carry it. Very safe. Um, so how do we give medication? So enteral drugs are drugs that go through the GI tract. Test question, enteral drugs are drugs that go through the GI tract, any portion of it. So it could be mouth to anus, anywhere in between, through a PEG tube, through a G tube, whatever, through a colonoscopy bag, doesn't matter. It's enteral drugs are drugs that go through the GI tract, any part of it, mouth to anus. Okay, so it could be oral or rectal. Parenteral drugs are different. These are drugs that will go through any route other than the GI tract. So this is IV, subcutaneous, which is underneath the skin, intramuscular, into the muscle, intraosseous. We actually have a procedure where we'll drill a screw into someone's bone. We go into their medullary canal and we'll pump IV fluid and medications through there. We do that in cardiac arrest as paramedics. It's something that paramedics do. Sublingual or buccal. So these bypass the liver when you do sublingual, means sublingual means under the tongue, by the way, or buccal. Remember, buccal is your cheeks. So remember the medicines that I'll give you an example. A sublingual medication would be nitro bid, right? So that's that first medication I showed you in that like brownish container. That's sublingual nitroglycerin. Buccal, that would be like glucose, oral glucose. And why is that important? I keep saying they bypass the liver. They get absorbed directly into the blood, and they don't have to go into the stomach through the portal system back through the liver. So it works really quick. So the reason we give oral glucose and oral nitroglycerin in the mouth, one of the many reasons, is because it bypasses the liver. It initially bypasses the liver. It's called first pass metabolism. It bypasses that. Now, transcutaneous and transdermal, we've talked about that. Intranasal, show and tell. I actually have one with me. Here's one right here. So there's this thing called an atomizer, and so we're seeing this a lot with like Narcan and even like pain medicine, like fentanyl and uh, medicine like odontatron and all sorts of medications. We're starting. God, Lee, I can't open it. We're starting to give through the nose, intranasally, and we're not injecting the nose, but what we're doing is this is like a squishy thing. What we're doing is we're putting the medication in a syringe and we're squirting it in there into a fine mist, show and tell. I'm going to make a mess for you guys in my office. Okay, hold on. Okay, so here's what we got. I got some methyl ethyl bad stuff, also known as water, sitting in the syringe now. And what you do is you put this in the, this is clean, in the patient's nose, and you close the other nostril and you push. And what happens is, I'm gonna make a mess just for y'all. It creates a fine mist. So just watch. Man, that went everywhere. So it creates a fine mist. And so what you do is you put this in the patient's nose and you inject some, and then you do the other nose and you inject some. And so that's how we administer Narcan. Currently, it's the most common way it's administered. It works really well. So that's intranasal. And the device, this thing right here is called an atomizer. 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 Wonderful way to administer medication. Very effective, very quick. I mean, not as quick as IV, but it's quick. And inhalation, that's different than intranasal. Okay. Now, pharmacokinetics. This is where we jump into some stuff, but we're almost done. There's like 5 slides left. I'm tired too. So, pharmacokinetics. So, basically, pharmacokinetics, as it says, is the study of metabolism, the action of drugs. So, how are drugs absorbed? How are they distributed throughout the body? How are they transformed throughout the body? Biotransformation, and how do we eliminate them? And so we know this about every drug that we carry on an ambulance or that we prescribe. We know how are they absorbed, how they're distributed, how are they transformed, how are they eliminated. We know that, okay? And then we have this thing called pharmacodynamics. It's different than pharmacokinetics. And this is a way in which a medication produces the response we intended. So basically, how dynamics means like how does it interact? How does it do what it does when it's in the body, right? So this also includes factors that may alter the intended response and any side effects or unexpected effects, okay? So the pharmacodynamics is basically when it's in the body, what is it gonna do to like different organ systems, and it's like what are the dynamics? What type of relationships is it gonna create in there? Okay? And so this is where we get mechanism of action. It's part of the pharmacodynamics, okay? And so remember me talking about the indication or I'm sorry, the indication or the action. These tightly relate to the mechanism of action. And so, you know, the mechanism of action of diphenhydramine is an antihistamine. The mechanism of action of uh, uh, nitroglycerin would be to cause venous dilation and vasodilation. So these are just examples of the mechanism of action. And so the magnitude of response depends on dose and the time it takes the drug to travel in the body. So we carry a medication on the ambulance called adenosine that has a half-life, meaning it lasts for half of its life is 10 seconds. Compared to we carry a drug on an ambulance called amiodarone, it has a half-life of 45 days. So they can vary, okay? And then after the medication is bound to the receptor site, it initiates a chemical change that produces the expected effect. Again, what does it do when it's in the body? How does it react with receptors and different organ systems? What does it do? So the drug response relationship, I drew this for you earlier, but I'll explain it now in writing. And so this correlates to the amount of medication given and the response it causes. So when administering a medication, we know the onset of action. So what is the amount of time it's going to take for the action, the antihistamine effects to affect? And then the duration of action is how long will it act? And the termination of action, at what point does it terminate? Okay? And you could put all these on a graph, but to me, they're kind of obvious in what they're saying. Onset of action, when does it start working? The duration of action, how long does it work? Termination of action, when does it quit working? Okay? And the therapeutic of index, so this is a ratio, this is what I was talking about earlier. This is a ratio of a drug's lethal dose for 50% of the population to its effective dose for 50% of the population. So I'll draw this out for you real quick. I drew it earlier. But so basically, we have a drug. And so what happens is we have to figure out where at on this chart is it's going to reach 50% effective along with 50% it's the 50% effectiveness of the drug mixed with, or I'm sorry, draw it this way, the 50% lethality of it. So it looks like this. So basically, this green area in between is called the therapeutic index. So we know that for half the population at this dose, it's therapeutic. It does what it's supposed to say. And then For half the population, it's toxic at this dose. And somewhere in the middle between those two is called the therapeutic index. Okay. And so somewhere in between here is where we try to treat. So you've probably seen that the dose for nitroglycerin is somewhere, or I'm sorry, aspirin could be somewhere between 81 and 324 milligrams, right? And so we look at different ways that medications are safe. So I will point out, and I'll draw this because I just scribbled all over that, right? Remember, the therapeutic index is somewhere in here. The wider the index, the safer the drug is. So I'll draw this out one more time. If here's the therapeutic index and here's the lethal index and it's really narrow, that means that you have to be really careful on your dosing because you don't have a large margin for error, because the difference between, oh wow, this is therapeutic and this is helpful, and like, oh wow, this is lethal, is very narrow on certain drugs. So the more narrow that is, the more, quote, dangerous the drug is or difficult to dose. So factors influencing medication interaction. Um, Interactions between medications occur when a drug is modified by another prescription medication. So that's something to be aware of. Patients will erroneously add prescription medications, or they go to one doctor and he prescribes one prescription. They go to another doctor, he prescribes a prescription that counteracts or works against that other prescription, and they go to the ER, and then the ER physician gives another medication. So be aware that different medications obviously interact with each other, and patients are usually, and even pharmacists and physicians are not aware that these drugs are interacting inappropriately, okay? Other thing, you need to ask patients, are you taking any herbal or over-the-counter medications? Patients tend to not think that certain herb medications are actual medications, and they get Instagram advice or TikTok advice, and they start trying to treat their AFib with essential oils or something like that, and it's harmful. So be aware that we should specifically ask, are you taking any medications over the counter or herbal medications? You should ask both those questions. Nicotine from cigarette smoking, sure. But I would say what's a bigger risk now in 2023 is vapes. Like vape pens, those can have a very high dose of nicotine in them. Something in the diet, an example is someone adding something to their diet, or someone abstaining from something in their diet. So someone who's vegan, or someone who doesn't eat meat, or someone who doesn't eat whatever, or someone who doesn't eat vegetables, right, could affect the way that their uh, medication works. I'll give you an example. You've ever heard of someone like a tyramine disorder? So someone takes the certain medication and they eat cheese or wine, ate processed or aged foods, they can end up with like a really bad reaction. So that's just there's many examples of food that can interact with medication. So anything to which the patient is exposed obviously can interact with their medication. So we have predictable responses, right? So if you take a bunch of Xanax and alcohol, you're probably going to overdose. Okay, and so because they're synergistic, right? They work together and they create a very strong response. But we also have this thing called iatrogenic response, and that's this. Iatrogenic responses are adverse conditions inadvertently induced in a patient by the treatment. Um, so these are like non-intentional. Okay, so like they don't know. Okay, so generally like iatrogenic, you should think like, well, they didn't know. Okay, they didn't know that that was going to happen. Unpredictable responses, this can happen with any medication, no matter how safe we think it is. Okay, um, we could just get adverse effects. There's adverse effects of every medication out there, and so we don't predict, we don't know. So someone could take aspirin and they could be allergic to aspirin, or it could cause serum sickness or idiosyncrasy, or they could get tolerance or drug dependence or interaction or antagonism or additive effects or synergism, potentiation or interference, right? What's synergism or potentiation? This is like when 1 plus 1 equals 2, or in synergism is like when you do 1 plus 1 equals like 4. I described this first one wrong. It's when like 1 plus 1 equals 4 instead of 2. That's the very quick example of synergism and potentiation. So, coming to a test near you, I'm going to ask you to just write these out. So you have to know these, okay? It's not going to be multiple choice either. You're going to have to like Spit these out at me. Okay? So I'm going to say, do you know your rights of medication administration? It's the right patient, the right medication and indication. I don't care if you do it in order. The right dose, the right route, the right time, the right patient education, the right to refuse, the right response and evaluation, and the right documentation. Yes, you need to know all of those, and yes, all of those should happen while and after before, while, and after administering a medication every time without fail. These are here to protect the patient and you. So be very aware. No surprise, it's coming. I'm going to ask you this, and it'll be a free response. One of the last slides. Um, this is an example of oral lingual angioedema. So this could be from an allergic reaction. It's unlikely. What this probably happened is from someone taking a medication called lisinopril. Uh, it'll cause swelling of the tongue randomly in some people that are missing an enzyme. So basically, just be aware this would be like an adverse effect that you really can't anticipate. So use a current reliable medication reference source. Have a patient confirm the volume in a syringe and the medication. So you want to make sure that, like, yes, the medication, this is the right dose, it's in date, it's not expired, this is the right patient, we have the correct order for this, right? Like all these things you want to confirm, and you usually want to confirm this with your partner. 2 eyes are better than 1 to confirm that. Something that you have to ask a patient before every time you administer a medication, and we will fail you on this as a critical point on your skills test, is if they're allergic. So you have to ask them every time, if you're going to administer aspirin, if you're going to administer Benadryl, right? Someone can be allergic to Benadryl. It's used to treat allergic reaction. Yes, they can. They can be allergic to the coating on it. So you have to be aware. Every medication you have to ask, sir, are you allergic to, or ma'am, are you allergic to any medications? And you have to go from there. Okay? So that's it. I appreciate y'all's time. I know this is a longer video. The general game plan is we're going to have drug cards as they coincide with each chapter that you're expected to know. So, like, for the respiratory chapter, you'll need to know a good chunk of them, right? So, like, albuterol and Atrovent and epinephrine. Like, you're going to have to know everything about that. And how we examine that typically is a regurg test. And I hate regurg, but you have to know them that well to where I'm going to hand you a blank piece of paper, essentially, and you're going to have to tell me the class and the contraindications and the adverse effects and the dose and all these other things. Okay, so you'll have to spit those out. So drug cards become really helpful for that. The good thing is, off the top of my head, I can only think of like 4 or 5 drugs. Epinephrine, albuterol, nitroglycerin, aspirin. Those are the top 4. Oral glucose. Those are the 5 that will definitely quiz you on. I might add a couple other like Narcan and stuff like that, but that'll be later on in the course. So just know that's how we tend to test those. Pharmacology is really interesting. Don't be bogged down about this. Of all the chapters that I'm like, I'll caution you, and I might should have started the video with this. I'm not going to specifically test you on metoprolol or something like that, but I might describe a 22-year-old male who was at a club who is now very agitated and fighting with police and has a heart rate of 188 and a blood pressure of 170 over 100 and has, pupillary dilation and is sweating profusely and is saying that he's Jesus Christ. What drug do you think he took? It's a stimulant. Okay? So maybe cocaine or amphetamine or methamphetamine or something like that. So, or even ecstasy or something like that. So just be aware that's typically how this is tested. I'm not going to ask you, what does beta 3 do? And I'm not interested in that. So just be aware, generally that's how that would be tested. So with that, I appreciate y'all's time. This video has been long enough. And that's it for now. Thank you.